Today we are having the Blood and Organ Donation Committee program, the CME, on the blood and all the different organs, how to donate and how to proceed. And this meeting is being organized by the Sivakasi IMA. Dr. Rashmi has taken the initiative. At the juncture, I welcome the speakers of the day, Dr. Paun Pandian, Dr. Anandiswari, Dr. Praveen Kumar, Dr. Ashok, and Dr. Kalpana. I welcome you all for this CME of the Blood and Organ Donation Committee. Now I invite our President, Dr. Sengutuvan sir, to inaugurate the program.
Thank you, Dr. Rajesh, for respected advisor for the Blood and Organ Donation Committee, Dr. Sukumar, Honorary Secretary, Dr. Karthik Prabhu, President, immediate past President, Dr. Abul Hasan, President-elect, Dr. Sridhar, Organ Donation Committee Chairman, Dr. Rajesh Babu, Moderator, Dr. Rashmi, Dr. Suguna Prabhakar, and speakers of the day. I think Dr. Chairman for the Organ Donation Committee is doing a wonderful job. Every month he is giving different topics to know how the program is to be conducted, and he is giving nice topics to every time to improve the knowledge of the participants. So I inaugurate the this Zoom meeting today. Thank you. Over to Dr. Rajesh Babu.
Now I invite Dr. K.M. Abul Hasan sir, the immediate past President sir.
Thank you, Rajesh. Good afternoon, all. Respected President, Dr. Sengutan, Secretary, Dr. Karthik, Dr. Sugumar, Dr. Rajesh, Dr. Rashmi, and all the office bearers, faculties, Dr. Paun Pandian, Anandiswari, Dr. Praveen Kumar, Dr. Ashok, Dr. Kalpana, and Dr. Rashmi. I thank all the faculties at the outset for accepting the offer from Organ Donation Committee and taking their valuable time off to speak to our attendees about organ donation. Dr. Rajesh has very brilliantly coined the topics for today's webinar, covering all the spheres of organ. The committee is doing a wonderful job every month, so that the organ donation, which is the milestone development in English medicine actually, and it is our duty to spearhead this organ donation and organ transplantation, and that job is very rightly done by IMA Tamil Nadu State Branch Organ Donation Committee. Congratulations. I wish all the attendees have a very good time, very important messages out of this webinar. And I thank Dr. Rajesh and organizers for giving me this valuable opportunity to say my remarks in the webinar today. Thank you very much, Rajesh.
Now I invite Dr. Karthik Prabhu sir, our Honorary State Secretary.
Yes, sir. Nice to see the activities of Organ Donation Committee, which is one of the very important committee. And not only that, it is important, it is one of the most problematic areas that we are touching in. Even if we are going to campaign for it, yes, there are many people, deserving people waiting, but the laws in which things are governed, a small error of thing can shut down the hospital completely. It's a very, very risky area, and I think even people involved in transplants should be knowing the transplantation norms and all other things. I think there should be a separate CME for that, those norms. But anyway, in such a thing where Dr. Rajesh Babu himself donated his body, he and his wife, and campaigning for that is very commendable. And of course, blood donation, Sugumar sir, maximum number of donations is done for a doctor or a person who can do. And I'm sure Dr. Rashmi and other team members are also doing a phenomenal job. Best wishes to the team, sir. Any support, we are always there. Thank you. Good day, one and all.
Thank you, Dr. Karthik Prabhu, sir, for your nice felicitations. Now I invite Dr. B. Sridhar, sir, the State President-elect 2025. Now I invite Dr. Gauri Shankar, sir, the Honorary State Finance Secretary, to give his felicitations. So now we will go straight away to the program. Now I request Dr. R.K. Rasmi, the core convener of the Organ Donation Committee, to take over the session and conduct the program. Welcome you, madam.
Hello,
Sir,
Rajesh.
facing, sir. Madam,
Really,
before that, sir, sir.
I really congratulate Dr. Rashmi. She was so enthusiastic in the last state council when I met. Really, she's doing a wonderful job, and she's so much interested in this eye retrieving center and blood donation. Really, I congratulate her. And Dr. Rajesh Babu, really a great. Nobody has conducted this ever. Every year, every month, you are conducting good schemes and topics. And really, I congratulate you. And let us start it. Thank you. Sir, start
Madam, start பண்ணுங்க.
Good afternoon, sir. Honorary State President, IMA Tamil Nadu State, Dr. Sankituvan, sir. Honorary State Secretary, IMA Tamil Nadu State, Dr. Karthik Prabhu, sir. Honorary State Finance Secretary, IMA Tamil Nadu State, Dr. Gauri Shankar, sir. Respected Chairman, Blood and Organ Donation Committee, IMA Tamil Nadu State, Rajesh Babu, sir. Respected Immediate Past President, IMA Tamil Nadu State, Dr. Abul Hasan, sir. Respected State President-elect 2025, Dr. B. Sridhar, sir. Respected Advisor, Blood and Organ Donation Committee, Dr. Sukumar, sir. Respected Convener, Blood and Organ Donation Committee, Dr. Suguna, madam. There is no great gift than a gift of life. By donation, we are giving someone a second chance to live. Organ donation is a multi-step process which begins with investigation into the cause of death and a multidisciplinary process which involves doctors from many specialties. A cadaveric donor can save up to 8 lives, whereas a living donor can save up to 75 lives. However, organ donation faces significant hurdles primarily due to lack of awareness, misconceptions, social stigma, and inadequate infrastructure. While Tamil Nadu is a model state with respect to organ donation, there is a substantial gap between the need and availability of organs. Organ Donation Committee, IMA Tamil Nadu State, with Dr. Rajesh Babu sir as its chairman and Dr. Sukumar sir as its advisor, and with tremendous support from state IMA leadership, Dr. Sankituvan sir, Dr. Abdul Hasan sir, Dr. Karthik Prabhu sir, and Dr. Gauri Shankar sir, has taken the humongous responsibility in spreading awareness in this regard. Despite the challenges, only organ donation offers potential solution to the organ shortage in India, and addressing the existing barriers and implementing comprehensive strategies and spreading awareness is the only solution to offer. I thank my speakers of the day, Dr. Pawan Pandya sir, Dr. Ashok sir, Dr. Anandishwari madam, Dr. Kalpana madam, and Dr. Praveen Kumar sir. Actually, apart from Praveen Kumar sir and Kalpana madam, I don't know any the other three speakers. I have never met them personally, but when I called them to give a talk on this regard, they were all ready, and thank you so much for that, sir. So I invite my first speaker, Dr. Pawan Pandyan sir, MD Anesthesia. He has done his MBBS from Russia. He has done his MD Anesthesia from CMC Vellore. He has vast experience in the field of anesthesiology. He has working experience, variable specialties, especially intensive care units in Government General Hospital, Trivandrum, SK Hospital, Trivandrum, St. Thomas Hospital, Chennai. He has joined Tamil Nadu Government Medical Officer Services from 2015 and worked as medical officer in Madurai, Tuticorin, and Virudhunagar. Now presently working as assistant professor in Government Medical College Hospital, Virudhunagar. His special interest includes difficult airway and cardiothoracic anesthesia. His research paper on thoracic surgery, that is double lumen endotracheal tube with camera won first prize in difficult airway conference at Tata Memorial Hospital, Mumbai. He is a recipient of Best Doctor Award from Virudhunagar Collectorate 2023. It's a pleasure to have you with us today, sir.
So all the members all are one and all here. So I just straight away go to that topic, sir. So the topic is mainly about anesthesia management for the organ donors. Especially, I'm going to talk about the neurological brain dead patients. So when we talk about the organ transplantation, it's as ma'am. Next slide, ma'am. Yeah. So when we talk about the organ transplant, it's always require the donation and procurement, right? And another thing is, it's not a simple process; it's a complicating process, and which we need a multidisciplinary teamwork. And so that we have to procure the organ properly, so that the patient who is receiving the organ has to get a proper out of it, right? So there are three types of organ donation we know. One is organ donation after the neurological death. Another one is organ donation after cardiac death. Then it's a living donor. So before going to the topic, we should just know about a little bit of the pathophysiologic changes after the brain death, right? Ma'am, next slide, ma'am. Next one. Next one. Yeah. Next, ma'am. Yeah, so we should know about the pathophysiologic changes of neurological death. Next one, ma'am. So what are the main organs are going to be affected by the neurological death is? One is main cardiovascular system, pulmonology and pulmonary system and endocrine, as well as metabolic and inflammatory changes will happen. Next, ma'am. So what are the main cardiovascular changes happening there are two phases are there. One is catecholamine storm, and second one is vasoplegia. So due to the catecholamine storm, that's happening mainly due to the raised ICP. There is a ischemia in various brain parts of the brain. Ma'am, next slide, ma'am. Yeah, next. Yeah. So due to the catecholamine discharge more, there will be a sympathetic discharge, catecholamine storm. So what will happen? Patient will have an increased SVR, tachycardia, visceral ischemia, acute MI, myocardial dysfunction. Next one, ma'am. Dysfunction and which will be the transient period. Yeah. Then the second phase is caused by the cerebral herniation. That actually brain death, how the things are happening is after the brain death, whether it's a traumatic injury or whatever the injury, there will be a disturbance of cerebral regulation. Perfusion will be disturbed, which lead to the ischemia of the brain, subsequently which leads to the herniation. Because due to the herniation, there will be a loss of sympathetic tone, which leads to a decrease your cardiac output. So first phase we see the hypertension, second phase we'll see the hypotension because of vasodilatation. Next slide, ma'am. So in overall, when you see, there will be a raised ICP, which leads to brady, hypertension, and sympathetic system, which leads to a local sympathetic tone increase, which seen as increased SVR like hypertension, tachycardia. Yeah. Then the respiratory changes. Next one. Yeah. So respiratory changes due to your sympathetic discharge is more. The shifting of blood from to the pulmonary circulation. So pulmonary circulation, there will be a capillary leak, which subsequently lead to your pulmonary edema. Yeah, which may triggers for SIRS, and as well as it increase the pulmonary endothelial permeability also. So what will happen? It leads to a graft failure. So when usually the lung donor will be less, if at all they're taking, we have to consider all those things, because as the fluid more accumulating, which may leads to a graft failure, and decrease the hormonal instability, which decrease alveolar clearance also, which may leads to apnea and death. Yeah. And the next one of the important thing is endocrine response. Yeah, 90% of the posterior pituitary will be next one. Click. Yeah, one more click, one. Yeah. So 90% of the brain dead patients, posterior pituitary will be affected. So they will be subsequently have a diabetes insipidus, as well as it affect anterior pituitary also, which may leads to deficiency of thyroid hormones, ACTH, as well as growth hormone. Yeah. The next one, ma'am. And most commonly encountered is metabolic response. Most common thing is hyperglycemia. That's mainly due to decreased insulin concentration and increased insulin resistance. The other thing is due to your hypothalamic function has been disturbed, you may encounter hyper or hypothermia. Then as well as we all know that brain has a more thromboplastin in the brain tissue. That's why most of the time traumatic brain injury patients, they easily go for the DIC because that it release the tissue thromboplastin from the brain tissue. So overall, the pathophysiologic changes, what we have seen is, I don't know, you skipped them. No, previous. Previous. Next one. Next one. Yeah. So this is overall the changes of which happening during your brain death. One is hypertension as well as, and the hypertension is second phase. Yeah. So that we had discussed out. So now we are going to see how to manage the patient before procure the organs for the transplant things. Next slide, ma'am. Yeah. So there will be a lot of physiological dearrangement after the brain death. So what we have to do is we have to maintain the euvolemic phase, maintain the cardiac output, and maintain the vaso, maintain the map also with minimum vasoactive drugs. So always you have to maintain the intravascular volume with fluids. You try to always maintain with the fluids. Better always with the crystalloids, not with the colloids, because colloids may leads to a kidney injury, which may leads to you cannot take the kidney later on for the transplant. And you have to maintain your map for 60 to 100. Try to avoid vasoactive drugs as much possible because it may leads to a vasoconstriction again. The organ perfusion will be disturbed. So if at all, if you're going for the vasoactive drugs, dopamine will be the first option because it has a pro-inflammatory effect as well as. Yeah. And as per the American guidelines, they always first line of choice will be vasopressin because vasopressin will reduces the catecholamine requirements and diabetes insipidus as well. Yeah. So the pulmonary management. So this is what I've talked about cardiovascular. The next one is the pulmonary. So lungs are usually the very difficult organ to retrieve. So you always should not overload the patient when you are trying for the next.
And which?
Next one, sir. Next one, ma'am. Next one. Click, ma'am. Next. Pulmonary. Yeah, next one. Yeah. Click one more time. So this is what? So recruit and retain lung units while limiting tidal volume and respiratory pressure, which means when you are planning for the lung recruitment, you definitely most of the time will be ventilating the patient. So use low tidal volumes, 6 to 8 ml, and use high PEEP so that the lung alveoli is not collapsed. Maintain the gas exchange. Then again, you use low fraction of the FiO2. Try to minimize your oxygen support as much possible, but maintain about 60. Yeah. So usually when we ventilate the patient, we look on to a PF ratio, which is to maintain your oxygenation. But here we should not see the PF ratio. So in some time we use a bronchoscopy also to remove the plex so that your lung has been clear filled. There should not be any stasis. Then as we talked about endocrinological support, you have to supplement by the hormones injections, tablets like ADH administration. Next one, ma'am. Like ADH administration, thyroid hormone replacement, where you don't have a thyroid hormone replacement, you can give a thyroxine tablet through the Rice tubes, right? Then steroid administration, differ by every institution. Some people, they give a methylprednisolone, but most of the time we prefer hydrocortisone, 100 mg TDS. Yeah. Yeah. And then fluid management, as we talked about, always prefer crystalloids, colloid try to avoid, and maintain the sodium less than 155 because most of the time brain dead patients, they might have a diabetes insipidus. So there will be a diuretic phase. So sodium will be more. So you have to correct the sodium and use crystalloids. Always maintain the sodium less than 155. Yeah. Then when you're taking the patient for a organ transplant, you have to maintain the rule of 100. Next one, ma'am. Yeah, rule of 100, what it means? You should maintain the systolic blood pressure more than 100. Your output supposed to be more than 100. And your PaO2 supposed to be more than 100. And hemoglobin is more than 10 gram. This is supposed to be maintained. Yeah, because once you maintain this only, you have to go for the apnea test. Once you're confirmed with the apnea test, then only you can decide for the transplant of organ. Apnea test, as you know, there will be 2 apnea tests, each 6 hours apart. Yeah. Ma'am, next one, ma'am. So we all, so before taking to that patient in theater, the anesthetist is ideally supposed to reach the ICU. He has to collect the all drugs and chart, everything has to be done. And he has to note the history of the incident also he has to note. And he has to review all the investigation which has been done. If it all not corrected, you have to collect the blood accordingly. Let's say if a hemoglobin is less than 10, you should take a reserve maybe 2 or 3 bloods supposed to be take with you. Yeah. And anesthetic is supposed to familiar with the organs which are going to be procurement. Yeah. So most of the time the incision will be midline, laparotomy, and it will be extended up to the sternotomy. So this we always know you have to maintain the cardiac output and BP all the map throughout the surgery, right? So here that neuronal is intact. So the both motor and autonomic spinal reflexes will be there. So during the incision or some painful patient may due to the reflexes are intact, patient may move the fingers. So you should not stop the surgery because this is not belongs to that. That's because of your spinal reflexes are preserved. So you can use either muscle relaxants or opioids for the analgesia as well. So usually volatile anesthetics also can be used. Volatile means gas, sevoflurane or isoflurane will be used, but most of the time we use sevoflurane. And the organ are removed in the following order, which are heart, lung, liver, small bowel, pancreas, and kidney. Yeah. Hello? Yeah. So, and after taking the organs, once the organs are taken out from the body and they put it in the ice slush, you can stop the ventilation, you can stop all the vasoactive drugs. So until that, you have to maintain all the drugs as it is possible. Yeah. As we talked about, maintain the map, maintain the output, maintain everything. The hemoglobin also has to be, even introp during any clamp, any blood loss happen, you try to improve your hemoglobin by transfusing the blood. Yeah. So these are the main thing which I'm talking about, the brain dead patients which coming for you, the anesthetic management. It's not only during the surgery, pre-op also we have to maintain. That is maintain all the parameters in the normal level and to maintain the cardiac output and BP. And during the surgery, the same thing has to be maintained. Try to minimize the vasoactive drugs, which at all possible. If at all need, then go with the dopamine and vasopressin. So I just stop here with that neural brain dead patients. Thank you, ma'am. Ma'am, I'm audible to you, ma'am. Rest all living donor, ma'am. I'm not talking about the living donor. I just wanted to complete this. Yeah.
Thank you,
My
sir.
reference, my reference will be Miller anesthesia and brain dead. Last slides, ma'am. My references will be. There are actually a lot of slides. I don't want to. These are my references, sir.
Okay, sir. Thank you, sir. Thank you so much.
Thank you so much, ma'am. Thank you so much.
Thank you so much, sir.
Thank you, Ananda.
I invite my next speaker.
We will have the questions at the end of all the speakers, huh?
Okay, sir. So
Okay.
I invite our next speaker, Dr. Ashok, sir. MD DM Nephrology. He did his MBBS from Vinayaka Mission Kribananda Warrior Medical College, Salem. MD General Medicine from Kasturba Medical College, Manipal. DM from Kasturba Medical College, Manipal. He is a fellow of Academy of General Medicine. He has vast working experience from various medical colleges, which includes Kasturba Medical College, Manipal, Savida Medical College, Chennai, Velamal Medical College, Madurai, currently working in Star Hospital, Satur. His publications include De Novo Focal Concentric IgA Nephropathy in Renal Allographic Recipient in Indian Journal of Nephrology. He has presented in various conferences, which include International Conference in Goa on paraneoplastic myasthenia gravis in neuroendocrine malignancy, and awarded Best Poster titled Role of Serum NGAL in Prediction of Graft Dysfunction Post-Renal Transplant in Indian Society of Organ Transplantation. It's a pleasure to have you with us today, sir. Over to you, sir, Dr. Ashok, sir.
Good evening. Am I audible, ma'am?
Yes, sir.
Good evening.
Yes, sir. Yes, sir.
First of all, I would like to thank the IMA Tamil Nadu State Branch Blood and Organ Donation Donor Committee for giving me this opportunity to speak about this topic. Today, my topic is a very interesting topic. It's crossing barriers in renal transplant. So, first of all, I will speak about the disease burden. The global prevalence of chronic kidney disease is between 5 to 13%. Whereas in India, the 2021 systemic review reported the CKD prevalence is between around 21% in different regions of our country. As we all know that CKD has emerged as a public major health problem of the 21st century. It leads to significant morbidity and mortality. The deaths due to the disease have increased has almost doubled since 1990. This is our map showing prevalence of the disease in various regions. In northern zone, it's around 7.2%. In eastern zone, it's 8.6%. In western zone, the prevalence is around 15.3%. In southern zone, it is 14.8%. So this is a rough estimate. In 2023, our kidney transplant around 13,642 kidney transplants were performed, and out of that 11,791 were living donors, and 1,851 were from deceased donors. So for a country of 1.5 billion people with an disease burden of end-stage renal disease around 2 lakh patients every year, these numbers are very tiny. This graph shows that indicate the huge gap between the demand and supply of our organs. So, what are the barriers to renal transplantation? Can be categorized as medical and surgical barriers, socioeconomic and geographic barriers, knowledge, awareness, and psychological barriers, systemic and policy-related barriers. So, coming to the medical and surgical barriers, there is as shown in the previous slide, there is tremendous organ shortage. There is a huge gap between the demand and the supply, so leading to a barrier. And there is incompatibility. Sometimes the donor and the recipient organs will not match based on the blood group and HLA. So there will be mismatch between the recipient and the donors, and there will be pre-existing recipient health issues such as cardiovascular disease, coronary artery disease, active infections, active malignancies. These conditions will hinder the recipient from undergoing renal transplant, and donor health issues. Sometimes what will happen is the donor in the family, they want to donate the kidney, but on checking up, they will have diabetes, hypertension, and proteinuria that will hinder the donor from donating the kidney. And surgical complications during the procedure as well as after the procedure. And during the procedure, patient might have excessive bleeding, infections, rejections the recipient can have, and delayed graft function they can have, which means that the organ once transplanted, it will not start working immediately. It will start working slowly, and even after a week it will start working. The recipient might be on dialysis for a week after transplant. And long-term complications such as risk of infections, risk of rejections, and the patient, the recipient will be on a lot of immunosuppressive medications. So medication side effects, all this form the medical and surgical barriers. Next, coming to the socioeconomic and geographic barriers, the many the socioeconomic, our countries, majority of the people are from the lower socioeconomic strata, so they have weak social support. They will have limited help from their relatives. The transplant system, sometimes the system, they feel, the patient and the relatives may feel it is very complex, and they have difficulty navigating that, and the lack of insurance, lack of financial support, all these things can have barriers. Sometimes a patient might live in a remote area, they won't have access to the proper medical facilities and transport facilities. So this can have these are all some socio-economic and geographic barriers. And knowledge, awareness, and psychological barriers. Sometimes the patient, the recipient, and the donor, they have limited understanding about the renal transplant. Lot of studies in our country showing that the recipient, the patient on hemodialysis, CKD patient on hemodialysis, as well as the common public, they have limited understanding about the renal, about the organ transplant in our country. They will have fear and misconceptions. The person donating might think that he will have a serious problem after donating, and he cannot resume the work. All those fears and misconceptions might be there. And psychological impact. Most of the patients on hemodialysis, they have a negative attitude towards the transplant, and most of them are in depression. Most of them are in severe depression, and a lot of cultural beliefs like they will hinder from the organ transplant, and communication barriers between the patient and the patient provider, physician. There are communication barriers. These are the barriers from the knowledge, awareness, and psychological point of view. So next, coming to the systemic and policy related barriers. Like some institutes, they lack disease donor programs. They were only living donor programs are there, and some organ allocation policies, legal and ethical issues, and transplant center policies. These will hinder these are from the barriers for organ transplant. And what are the strategies to overcome these barriers? First, we will speak about the immunological barriers. And now the many centers started doing ABO incompatible transplant, which means transplant can be done between the donor and the recipient, even their the blood group not matching. So it can be possible by using various desensitization protocols, which involves plasmapheresis and immunosuppression prior to the transplant to decrease the production of the antibody. And novel immunosuppression, newer immunosuppressants are available, which will make the rejection rates very less. And third is live donor exchange program, as we saw in the Dr. Rajesh Babu sir has shown the video. That is called live donor exchange program. Then between two hospitals, Ramakrishna Hospital and Gem Hospital, the liver transplant has happened between two different recipient and two different donors because of mismatch. So this can be possible. This can overcome the immunological barriers, live donor exchange programs, and improving HLA matching algorithms. We can feed different patients HLA into the computer, and we can see which person matches better. So that the rejection rates and the post-transplant outcomes are better. And next, how to overcome the organ shortage. One is we have to motivate the living donor transplantation by giving proper education to educate the relatives of the patient and give proper support to them. And we can create public awareness campaigns, increase the donor registration, and we can expand the donor criteria. Now, for good recipient outcomes, there are certain guidelines that the donor has to be, like the age criteria is there, and some medical conditions should not be there. Those criteria, we can expand it. Actually, we can include slightly older donors, and some medical conditions, with minor medical conditions we can include, so that we can expand the donors. And now the area of active research is xenotransplantation. And so xenotransplantation means transplantation happening between different species. So these are all the long-term solutions. So much research is going on into the xenotransplantation. So this is how we overcome the organ shortage in our country. And how to overcome the geographic disparities by One is a telemedicine support. We can, the main transplant center can provide telemedicine support, can provide remote consultations, specialist consultations, and we can educate the public using telemedicine, and we can educate the patient using telemedicine. And regional collaboration. We can, the main transplant center can start a satellite unit in the periphery, in the remote area, where the patient, the recipient can get benefited. So we can share the transplant center can share the resources and expertise. And financial assistance programs. We can like we can the foundation, like many people have started that like foundation, and we can get the financial assistance from the patients who are deserving, and the standard referral criteria has to be there. And so that if there are many studies have shown that when you refer the patient early, the rate of conversion to transplant is more. If you refer very late the patient on dialysis, the patient will have a negative attitude towards the transplant. So they must have in the earlier stage itself, the CKD patient has to be seen by a nephrologist and counsel for transplant. As we all know that renal transplant improves the quality of life, and there is a definitive survival advantage than the hemodialysis. So we have to counsel them early and convert them into transplant, so that to improve the quality of the life. And how to overcome the financial barriers. We can give insurance coverage, financial assistance programs, medication assistance programs, and cost-effective analysis. All these things we can do. And how to enhance the social support for these patients. They can form a group, peer support groups. The transplant patients can form a group, and they can share their experiences through the groups. So they will get moral support as well as some social support. You can give proper counseling. Counselor has to be appointed, and then proper counseling has to be given. And family, you can educate the family, provides effective support to them, and community partnerships. We can involve various NGOs and collaborate with them and give additional support services. And next is psychological support. We can transplant patients. Mental health screening has to be done periodically, and psychotherapy needs to be given. If we feel they are depressed and this thing, immediate referral to psychiatrist, and mental health screening has to be done, and medication management has to be done. Mindfulness based interventions needs to be done. And how to enhance this thing, adherence, like medication adherence in kidney transplant patients. They have to educate about the follow-up visits and the blood investigations, about the complications, when to see the doctor, and all those things. They will be properly educated. Medication reminders needs to be it will make their this thing easy at when to take these medications, and simplified regimens. Physician has to give the simplified regimens to the patient, so that they can follow properly without any default. And we can motivate. We have to motivate them. We have to interview them and motivate them. And this is a slide showing this overall summary of the slide. These are all the various social, cultural issues, like system level factors, and family support, psychosocial support. So if you overcome these barriers, we can increase access to the organ transplant. So conclusion, the barriers of the kidney transplant, from the patient side, from the provider side, from system level, there are various barriers are there. It needs multi-level interventions to overcome these barriers. The providers, dialysis facilities, and the transplant centers should work together to increase access to the transplantation. Significant policy changes are needed, so that to give extended health coverage to these patients, and access to specialists in transplant centers and organ allocation. Thank you.
Thank you, Dr. Ashok sir. I invite Dr. Anandeshwari Madam, MD, Immunohematology and Blood Transfusion, for the next talk. She has done her MBBS from Madurai Medical College, MD from Madurai Medical College, and currently working as Assistant Professor in Blood Center, Virudhunagar Government Medical College, and District Medical Transfusion Officer, Virudhunagar District. She has many publications to her credit. Prevalence of weak D blood group variants among blood donors in a tertiary care hospital in South India. A case of delayed hemolytic transfusion reaction with conjugated hyperbilirubinemia in an antenatal mother. An insight into quality control of blood components in a tertiary care hospital in South India. And a cross-sectional study on knowledge, altitude, and practices of blood donors towards blood donation in a tertiary care hospital in Madurai. It's a pleasure to have you with us today, madam. Dr. Anandishri, ma'am.
Ma'am, am I audible? Thank you, IMA, for this opportunity. Ma'am, can you share your screen? I've sent you the topic. Topic is apheresis and its application.
Ma'am? Ma'am, can you see the slides?
Yes, ma'am. Ma'am, am I audible?
Yeah, you're audible.
Okay, ma'am. Topic is apheresis and its application. This is the overview. And necessity is the mother of all inventions. When the necessity of blood banks has arose, it is during the period of World War around 1940s. At that time, the whole blood was collected and distributed to the patients in the needy state. That was the first thing started. And during the period of 1945, in India also in West Bengal, the first blood bank was started. At that time, the whole blood component alone is also there. In 1960s, all over the world, the countries have started component separation technology into them. In 1990, India has also started component separation facility. Now, almost all the blood centers started adopting component separation technology, and the whole blood usage is almost obsolete now, except in very few cases. Now, the recent advancement in the field of transfusion medicine is apheresis technology. The demand is still increasing nowadays. So the need for blood and blood components by newer technologies is in the right demand nowadays. Let us go to the introduction of apheresis. It is a Greek word which means to separate or to remove. This was first coined by Abel et al. Ma'am, the first slide itself, ma'am. Introduction slide. It was coined by Abel et al., a Greek word. In 1959, a first case of plasmapheresis was done for a case of Waldenstrom macroglobulinemia by Scrooge and Adams. This is the history which made to a separate branch called apheresis physicians. And what is the definition proper? For apheresis, blood is withdrawn from a donor or a patient in an anticoagulant solution and separated into blood components. Then one or more of the blood component is retained and the remaining constituents are returned to the donor or into a patient. Next slide. This is the typical picture of apheresis room. We can see two cell separators, that is apheresis machines, the yellow color and the white color one, and these are the donor couches. According to Drugs and Cosmetics Act, an apheresis room should be attached to a hospital. A donor apheresis facility can be in standalone blood centers, but therapeutic apheresis should be in hospital settings only. And according to the Act, 10 meters square minimum area is needed for an apheresis room, and air conditioned facility is a must, and emergency drugs and oxygen supply must be there for donors as well as for the therapeutic apheresis patients. Next slide. These are the various cell separators available in the market. According to our demand and the case load, we can choose the type of cell separator our center is in need. Next one. Next. The basic steps in apheresis is first is the component separation and then removal or reconstitution of the desired component. First, the separation is done with the help of filtration process or by centrifugation process. Filtration uses differences in size of the blood and components. We know that platelet, the size is 3 microns and the granulocyte size ranges of 13 microns. With that, the filters, the efficiency of the need is by the pore size of the filter we use. And for centrifugation, the specific gravity is the main marker which concludes the efficiency of the separation. We know the plasma has a specific gravity of 1.02 and the platelet 1.04 and lymphocytes 1.07, granulocytes 1.08 and the red blood cells in the range of 1.093 to 1.096. First, the membrane filtration. We could see this is the the previous slide. This is a membrane filtration in a dialysis machine. It is, we could see that there is a parallel single hollow fibers in the plastic cylinder. The whole blood will be entered at one end and plasma will be squeezed out through the walls and it will flow through it, and concentrated cell suspension exists the other end of the filter. This is mostly done in case of plasma separation alone. Next one. But nowadays, the most common principle for separation is the centrifugation principle, which is based on the principle of specific gravity. According to the specific gravity of the blood components, they will get settled in the centrifuge machines. And we could see the interface of the plasma and the red cell components. This interface will be measured by automated interface management in the centrifuge machines, and they will decide which component to be harvested in the procedure. Next is combination of both centrifugation and filtration methods of separation of blood components. This is used nowadays in many of the equipments. This is in the new trend. This combines both technologies of centrifugation and filtration. The plasma passes radially through the filter membrane and gets collected. The cellular elements return to the donor bag, and this combination permits the use of lower G-force and smaller filter surface area. This has separation efficacy higher than any other method of technology. There are also different types of centrifuges, that is the cell separator machines we should know. First is intermittent flow separator and is continuous flow separators. Intermittent flow separators, they separate whole blood into components in batch by batches. For example, if a procedure is for 2 hours, it will first collect in the first 15 minutes and then centrifuge it, separate the components in the next 15 minutes and will be returned. Likewise, batch will be there. So to make another batch, the previous batch should be emptied and then only the next batch will be processed. So it's a lengthy process. It will be taking around 2 to 3 hours. In continuous flow devices, the separation and return to the patient will be done simultaneously. But it is a costlier instrument. But nowadays, this is in the trend. Many hospitals are acquiring continuous flow centrifuge devices. Next slide. Okay. Next one. Hemanetics MCS, most of the government hospitals are having this hematic cell separator system in the medical colleges. This is a small portable which is suitable for off-site on mobile collection units. It's a portable one, so easy to carry, very smaller size. And this is a perfect example of intermittent flow centrifugation. Next one. This is Spectra OPTIA. This is a continuous flow centrifugation equipment where the procedure will be completed within a span of 45 minutes to 1 hour. Each procedure is customized based on entered data. With this machine, even the stem cells collection up to can be done. Cell or plasma interface monitoring device, automated interface management is there, which enables the separation efficient. Next, the modalities. There are various modalities of apheresis. First one is therapeutic apheresis. Next one is preparative apheresis. Therapeutic means it is done in patients. That is, it is an extracorporeal therapy, either removes or discards specific blood components or collects and manipulates specific blood components ex vivo and reinfuse back to the patient. And then preparative apheresis, this is done in donors. It's a procedure in which specified blood components are collected from donors for therapeutic purposes to the patients. Next. Various modalities of therapeutic apheresis alone. First and most commonly used one is the therapeutic plasma exchange. It is also called as TPE or PLEX. Then red cell exchange is there, double filtration plasmapheresis, immunoadsorption, lipoprotein apheresis, extracorporeal photopheresis, therapeutic leukapheresis, thrombocytopheresis, erythrocytopheresis. These are all various modalities among therapeutic apheresis. Next one. This is a circuit diagram of what therapeutic plasma exchange is done. She's a patient from whom we have to remove the plasma. Her blood is collected through a pump with an anticoagulant solution and sent into a cell separator. After centrifugation, the plasma will be sent to the waste container and the remaining blood components will be sent back to the patient again. But before that, replacement fluid like albumin will be given according to the need and demand of the patient. Next one. This is the proper definition of therapeutic plasma exchange, which is one of the most commonly used modality of apheresis. It's a procedure in which patient's plasma is separated from other blood components by either membranous centrifugation or through centrifugal separation. And the patient's plasma is replaced with substitute solutions such as it may be a human albumin or a plasma or a crystalloid solution or a mixture of all these depending upon the underlying clinical condition. Next. These are the various conditions, clinical conditions, which can use apheresis as the treatment of choice. Let us discuss in detail in the next slide. What is the guidelines which are managing all these apheresis technology? It is under American Society for Apheresis. Every 3 years, they are revising the guidelines. The recent guideline is 2023 guidelines. There are many clinical conditions and they have categorized them into 4. What is category 1? It is that the disorders or the clinical conditions for which apheresis is accepted as a first-line therapy. That is, it can be used as a primary standalone treatment or in conjunction with other modes of treatment. We'll see what are the category 1 conditions in the next slide. And the category 2 means disorders for which apheresis is accepted as second-line therapy, either as standalone or in conjunction with other modes of treatment. For category 3 indications, ma'am, previous slide, previous. The optimum for category 3 clinical conditions means the optimum role is not yet established and decision should be individualized. And category 4, institutional review board approval is desirable if apheresis treatment is undertaken because there is no proven evidence for apheresis in these clinical conditions. Next one. How the effectiveness of therapeutic plasma exchange is decided. It is mainly based on 2 factors. First one is the amount of plasma removed from the patient's total plasma volume, and then distribution of the target pathogenic substance between the intravascular and extravascular compartment, and how quickly the pathogenic substance rebalances between these 2 compartments. The amount of plasma removed means whether it can be a low volume plasma exchange or a high volume plasma exchange or a normal volume plasma exchange. Depending upon the clinical condition, we have to decide on which one to be chosen. Next, the distribution of the plasma. This is the graph which shows in x-axis we have the plasma volume replaced in the patient and y-axis has the percentage of pathogenic substances removed. We could see that maximum amount of plasma replacement which is done in 1.5 volume and 2 volume will have a good removal of 77% and 86%. So 1 volume of plasma removal removes 63.2% of the unwanted and pathogenic substances and autoantibodies, whereas 1.5 times of plasma volume removal will lead on to 77.7% removal and 2 volume removes 86.5. And after that, more than 2 volume of removal, that is around 2.5 liters, there will be lesser benefit. We have to decide on the risk benefit ratio because if more of the volume is exchanged, hemodynamic instability and other adverse reactions may be possible. So it's better to replace the volume plasma exchange to be done in 1 to 2 plasma volumes. Next slide. What are the other factors which affect the therapeutic plasma exchange efficacy? First one is the distribution of immunoglobulins. I have said many of the disease conditions, it may be an IgG or IgM type of antibodies. In case of IgM antibodies, its distribution is 75% in the intravascular compartment. So in such clinical conditions, a single session of therapeutic plasma exchange will be enough. And it can be done in shorter intervals. But in case of, if the pathology is due to IgG type of antibodies, the antibodies will be in the extravascular compartments, and in such cases, longer interval shows greater benefits. If one session of plasma exchange is done today, then we have to wait for some 3 to 5 days to do the second procedure, depending upon the distribution of the immunoglobulins, as well as if the half-life of the immunoglobulin is shorter, then there will be lesser clinical effect of the apheresis. And the synthetic rate, if the rapid synthesis is there in the antibodies, there will be decreased efficacy in the therapeutic plasma exchange. Next. What are the other points to be considered while doing a therapeutic plasma exchange? First one is the written consent is the most important one. Next, vascular access. Though central venous access is not mandatory, if the peripheral venous access is not in a permeable moment, we can go to the central venous access. Next important one is the extracorporeal volume. Extracorporeal volume is the volume of blood which is outside the patient's body or the donor's body, that is within the machine's apparatus. So the total blood volume should be calculated for a patient, and 15% of the total blood volume we have to calculate, and that should be within the range of extracorporeal volume of that particular machine. Most of the machines will have the extracorporeal volume as 150 to 500 ml. If you take Haemonetics machine, intermittent flow, we can have 500 ml of extracorporeal volume. Whereas in continuous centrifugal machines, we have 150 ml of extracorporeal volume. So it should be decided that the 15 should be less than 15% of the total blood volume. Next is calcium supplementation. In all the procedures of apheresis, we are collecting blood in anticoagulant solution. So most commonly the anticoagulant we use the acid citrate dextrose, and that citrate is a calcium chelator. So there are high chances the patient or the donor will go on to hypocalcemia. So in case of healthy donor, in case of platelet apheresis or any donor apheresis procedure, oral calcium supplementation before the procedure is mandatory. And in case of patients, intravenous calcium gluconate is mandatory, and calcium levels to be monitored before and after the procedure. And replacement fluids, it should be decided how much to be replaced depending upon the volume status of the patient. And also the type of replacement fluid, it can be albumin or a fresh frozen plasma. In case of thrombotic thrombocytopenic purpura, we cannot use fresh frozen plasma. It is better to use albumin. In conditions like acute liver failure, the coagulation factors are lost. So in such cases, fresh frozen plasma is a good choice. So depending upon the clinical condition, it should be decided. Adverse events during the procedure, though it's a let us see the clinical conditions. Category 1 clinical indications by American Society for Apheresis, where apheresis technology can be used. Neurological conditions, first we take into that. First one is demyelinating polyradiculopathy. In that, both acute and the chronic indications are there. And then is the myasthenia, moderate to severe myasthenic crisis in conditions of refractory disease activity, that is high level of anticholine receptor antibodies are detected, means we can use the apheresis technology. It is also helpful in NMDA antibody receptor encephalitis. Next one. When we take the nephrological conditions in which apheresis can be used, first one is the Goodpasture syndrome or antiglomerular basement membrane disease. In those conditions, if there is diffuse alveolar hemorrhage and dialysis independence, Goodpasture syndrome, apheresis technology will be helpful. And in case of FSGS, in recurrent, which is recurrent in the transplant kidney, is also be apheresis technology can be used. And in case of ABO incompatible kidney and liver transplantation also we can use. In the desensitization protocol also, apheresis can also be used till the desired titer level of antibodies is reached. Next one. Next, hematological conditions. In case of catastrophic antiphospholipid syndrome, the autoantibodies will be removed, and so it will be helpful along with other treatment modalities. Hyperviscosity in hypergammaglobulinemia, and in case of thrombotic microangiopathy, which is complement mediated, where the facilities don't have ecclusemia, will get benefited with the apheresis technology in conditions of thrombotic microangiopathy. In conditions of thrombotic thrombocytopenic purpura, it will be very helpful. Many cases have been recovered in the recent days with the help of apheresis technology in case of TTPs. But the one thing is, within 24 hours, the procedure should be initiated to have a good clinical results. In hepatic conditions, acute liver failure, till transplantation occurs, we can be used. Acute liver failure due to any cause can also be managed. And the other condition, fulminant Wilson's disease, can also get benefited from apheresis technology. Next one. When we say acute liver failure, globally, the most common cause is acetaminophen toxicity. The other conditions are viral hepatitis and hepatotoxins. But in Tamil Nadu, NHM made a survey, and it was shocking that the rodenticide ingestion, especially yellow phosphorus phosphate poisoning, is the most common cause of acute liver failure in southern parts of India, especially in Tamil Nadu, due to yellow phosphorus poisoning. And that is the young males. So a study was conducted by CMC Vellore and other major hospitals in Tamil Nadu, which has shown that Plex has an effective treatment option, and it mainly acts as a bridge therapy till the transplantation is done. And most of the patients are not affordable for transplantation. So Plex acts as a bridge therapy in those patients. Next one is the Tamil Nadu branch of Indian Society of Gastroenterology guidelines on rodenticide poisoning. They have advocated for rodenticide poisoning 50% volume, that is total among the 50% among the total volume, 50% of the plasma is to be exchanged per session, and the preferred replacement fluid is FFP in the ratio of 1:1. Centrifugal plasma exchange is preferred over membranous plasma exchange. The frequency they have advocated daily for 3 days. The total sessions depends upon the clinical condition and tolerability of the patients. Next slide. What are all the indications they have said in case of rodenticide poisoning and plasma exchange therapy? Indications: the INR should be more than or equal to 4, and there is worsening of INR on serial investigations, and if there is depressed consciousness or altered behavior in rodenticide poisoning cases, we can advocate to therapeutic plasma exchange therapy. What are the contraindications? In case of hemodynamic instability and in case of active sepsis, therapeutic plasma exchange is not advocated. What is the other therapeutic modality in apheresis is the red cell exchange. The deceased red cells will be exchanged and donor healthy red blood cells will be replaced to the patient. This is most helpful in conditions like sickle cell disease. The indications are acute stroke in sickle cell disease or for conditions like stroke prophylaxis. It's a category 1 indication, and category 2 indications, that is it can be act as a alternate treatment modality in conditions of sickle cell disease, where the indication is acute chest syndrome and recurrent vaso-occlusive crisis. Next modality of apheresis is extracorporeal photopheresis. This is done in case of Sézary syndrome, T-cell cutaneous lymphoma. In this condition, the whole blood will be removed and it will be given 8-methoxysuralin and UV radiation, and the buffy coat will be sent back to the patient. This is also another treatment modality. Next one is double filtration plasmapheresis. In this, 2 different filters after the plasmapheresis was used, and a separate immunoglobulin will be observed and the blood will be returned back to the patient. Next is lipoprotein apheresis. The same principle in that the lipoprotein will be absorbed from the liposorbor columns after plasmapheresis. This is helpful in conditions like hypercholesterolemia, hyperlipoproteinemia. Next, another type of apheresis, that is the preparative apheresis. This is done in case of donors. Donor apheresis, single donor blood component harvesting, it is also otherwise called. If you remove plasma, it is called a plasma apheresis. If you remove platelets alone from a donor, it is platelet apheresis, or it is also called a single donor platelets. And if you remove red blood cells alone, it is called erythrocyte apheresis. Sometimes double unit of red cells can also be collected for usage in antigen matched units to be needed. And in case of removal of leukocytes, it is called as leukapheresis, and removing granulocytes, it's called as granulocyte apheresis. It's also one of the modality which comes as peripheral blood stem cell collection. Next. This is the diagrammatic representation. In preparative apheresis, blood will be withdrawn and it will be separated by components by a centrifuge. Needed components are collected in a sterile bag and unused components are returned back to the donor. Next one. And before whole blood and apheresis donation proportion in various countries. In the first graph, we could see the brown one are the apheresis donation and the blue one are the whole blood donations. It is higher in case of AMR, that is American countries, and in European nations. In the other nations, it is in the lesser range only. So it is evident that many of the developed nations are towards apheresis rather than whole blood donations. Next graph shows low income, middle income, and high income countries, and we could evident that the maroon one, which shows higher in the high income countries, that indicates that apheresis donations are higher in the high income countries. Next slide. Why the world is moving towards apheresis donation than the whole blood donations? What are all the advantages of single donor apheresis blood components? It reduces the multiple donor exposure. Since multiple donor exposure is reduced, there is the reduced risk of alloimmunization and transfusion transmitted infections. And there will be better quality product from the apheresis technology, and the dose will be in adequate range. For example, 6 random donor platelets will be replaced by single donor platelets of 1 unit. And also the products from the apheresis are leukoreduced. So the leukoreduced blood components will be helpful in case of transplant units, hematology units, because there will be reduced risk of febrile non-hemolytic transfusion reactions, and also HLA alloimmunization will be reduced, and CMV transfusion risk will be reduced in case of leukoreduced components. And also platelets produced from the apheresis technology, that is single donor platelets, the shelf life can be increased by adding the platelet additive solutions. Routinely, platelets have a shelf life of 5 days only, but if it is from the apheresis technology, additive solutions can be infused and it can be used for a period of 2 weeks also. But the disadvantage of single donor apheresis blood components is that it's a costlier procedure. The equipment itself costs around 40 lakhs around, but also trained manpower is needed. Next one. Advantages of single donor apheresis blood component. Before that, for blood components, for blood donors, reduced donor adverse reactions, because only one component will be removed from the donors. So the adverse reactions will be less. And also if a donor has the giddiness or other adverse reactions, mean fluid replacement can be done with the help of apheresis machines alone. So they will have a pleasant donation experience, and the smaller needle technology will be there, will be having lesser venous injuries. And the donation interval is lesser than the whole blood donation. For whole blood donation, we have a donation interval of 3 months for males and 4 months for females. But in case of single donor platelets, 24 hours to 48 hours we can wait, and the next donation can be done in 2 days. But the disadvantage is that longer duration of procedure. The whole blood donation takes only 15 minutes, whereas apheresis donation for single donor platelets and others will take 45 minutes to 1 hour. And also the donor eligibility is different. According to the National Blood Transfusion Council, the donor eligibility for a whole blood donation is entirely different from the single donor platelet and stem cell collection donor. Also, the investigations are additionally needed for single blood component donor. So the take-home message is, it's an underutilized technology and its use should be increased. Only few colleges in Tamil Nadu is having transfusion medicine departments, and in that colleges alone has apheresis equipments. Recently, new medical colleges, 7 new medical colleges are also provided with apheresis equipments. So it should be increased the utility of that equipments. It's a safe procedure. Apheresis itself is a safe procedure. It's life-saving in many of the resistant cases and refractory cases, and with less adverse reactions to the donor in case of donor apheresis also. But understand the pathophysiology and plan treatment protocol depending on the case-by-case basis. It's an individualized approach for the patient. A patient differs in their pathophysiology. Likewise, the treatment protocol, the type of the kit used, everything should be individualized. And apheresis is a newer technology. It should have adopt evidence-based practices. Thank you, ma'am.
Thank you, madam. Thank you for that detailed explanation. My next speaker is Dr. Kalpana. I invite Dr. Kalpana for the next talk. She has done MBBS from Kanyakumari Medical College and post-graduation from Government Stanley Medical College, Chennai. She has worked in ESI Hospital, Savagasi, and she was awarded the COVID Warrior during the COVID times. Currently managing Kannan Skin Clinic in Savagasi. Over to you, Kalpana. Dr. Kalpana.
Kalpana, dermatologist from Sivagasi, and today I will be presenting in crisp about skin donation and skin banking. So skin donation is the process of donating skin after death. But compared to blood donation, corneal donation, or any other organ donation, skin donation still remains a relatively new concept, and many common people are even unaware of the fact that skin can be donated. but it's a very simple procedure that offers much better quality of life, especially to burns victims. Citing a short note on the magnitude of burns cases in India, more than 7 million people in India suffer from burns injuries every year. It is the second largest group of injuries after RTA. About 1 to 1.5 lakh people get crippled and are in need of multiple surgeries and prolonged rehabilitation following burns injuries. So what can be done about it? A lot can be done with the help of skin donation. As we all know, skin is the primary protective barrier to the body. So when skin gets badly burnt or damaged, excuse me, sir. Am I audible?
Yes, madam, you
You
are
are
audible.
audible, ma'am.
Thank you, sir.
Audible,
When skin,
madam. Nice.
yeah. When skin gets badly burnt or damaged, it's unable to repair and heal on its own. If the burnt area is not covered immediately with some skin substitute, then the patients are more prone to infection, fluid loss, and ultimately death. We have many skin substitutes like synthetic polymer sheets, collagen sheets, xenograft, and even amniotic fluid membrane. But still, cadaveric skin is the best and cheapest substitute for skin. It acts as a temporary dressing, prevents infections, decreases pain, helps faster healing, provides protection, and also helps patients' own skin to regenerate. So we can save many patients from crippling if we have enough skin in skin banks. Now, who can be a donor? So anyone, irrespective of sex and blood group, can donate our skin. The minimum age group is 18 years and there is no upper age limit. As like any other organ donation, the contraindications include patients with HIV, those suffering from other STDs, any kind of skin infections, patients with hepatitis B and C, any kind of generalized infection like pneumonia, TB, patients with malignancy, and patients with septicemia. Now, how can we donate our skin? We can register through official website www.organindia.org, or they have a toll-free number. We can contact them directly and also register. Also, for skin donation, prior registration is not mandatory. Skin donation can also be done just with the consent of the family member after death. If there is skin bank in our locality, we can contact them directly and approach for skin donation. So a skin bank is a facility that collects, processes, and stores skin grafts from deceased donors to be used in treating burns victims and other patients with skin loss. So the procedure for skin banking is very simple. It involves only 3 phases. In the first phase, the skin is harvested. In second phase, the skin is processed in glycerol. And in third phase, the skin is preserved. I'll explain in short about these. Call from the relative of the deceased. The skin retrieval team arrives. They check for the cause of death and presence of any contraindications. Then they verify the death certificate and take consent of the relative. Blood samples are taken to test for HIV, HBs antigen, HCV, and VDRL. Then the process of retrieval begins. So it starts with shaving and cleaning the body and scrubbing with betadine. Then it's cleaned with Savlon followed by sterilium. Then the parts are lubricated using paraffin oil. Skin is harvested only from legs, thighs, and back. Harvesting is done using dermatome. Only 1/8 of the total thickness of the skin is harvested. After harvesting is completed, the parts are bandaged and the body is handed over to the relative. The skin thus harvested is preserved in 50% glycerol and transported to skin bank. Once it reaches skin bank, phase 2 begins. In phase 2, the skin is cut into regular sizes and then transferred to 80% glycerol. Then they are placed in a shaking incubator at 33 degrees Celsius for 3 hours, followed by an incubation period of 3 weeks. Once the incubation period is over, phase 3 begins. In phase 3, the skin is processed and meshed. Then they are placed in labeled vials and preserved at 4 to 8 degrees Celsius for almost 5 years. So some facts about skin donation. Skin harvesting is done within 6 hours from time of death. As I already mentioned, only 1/8 of the total thickness of skin is harvested, and harvesting is done only in the legs, thighs, and back. There is no bleeding or disfigurement, and no matching is required. And the shelf life of processed skin is about 5 years. So short note on skin banks in India. The first skin bank was established long ago in 1978 in Mumbai by Dr. Manohar H. Keswani. But this bank failed because of lack of monetary support and awareness. A breakthrough in skin banks occurred when Dr. Madhuri Gore established one in Sion Hospital in Mumbai in 2000, followed by RCBN Skin Bank in Mumbai in 2009. At present, there are 22 functional skin banks in India across various cities, including Chennai, Bangalore, Mumbai, Delhi, Bhubaneswar, Coimbatore, and Madurai. And regarding skin banks in Tamil Nadu, the first government-run skin bank was set up at Government Stanley Medical College, Chennai in August 2016. We also have skin banks at Ganga Medical Center and Hospital, Coimbatore, Rites Hospital, Chennai, Government Kilpak Medical College, Chennai, SRM Institute for Medical Sciences, Chennai, and Rotary Community Skin Bank in Madurai. So what's the need of the hour? So it's very sad to say that myself, being a native of Sivagasi, the cracker city, we face minimum of 5 to 6 blast injuries every year and are losing lives, and nothing much could be done for that. I think that's why Dr. Lakshmi ma'am wanted to establish a skin bank in this locality. In general, in India, we are in need of increase in number of skin banks. At least one skin bank can be established in each district attached to Government Medical College Hospital or district headquarters hospital. The skin banks in India at present is very less compared to the demand and need of skin. Also, establishing a skin bank attached to burns unit can be of much help because there will be easy availability and we can avoid delays in procurement of skin. The next important thing is creating awareness among common people. Skin donation can be a success only if common man comes to know about it, how to donate the skin, what is the process, and how it can be helpful. So this can be achieved through social media, by giving talks at schools, colleges, workplaces, government offices, and religious places, by conducting organ donation rallies, by distributing flyers, and we can also do electronic display in people waiting areas like hospitals, railway stations, and bus stands. We can collaborate skin donation program with cornea and blood donation program so that people become more aware of skin donation. So I'd like to conclude by saying, let's donate our skin instead of burying or burning so that it will be a great service to people in need. Save your skin, save a life. Thank you. Thank you for the opportunity.
Madam, nice, madam.
Yeah, thank you, sir.
Conneyakumaரி Medical Stanley நல்லா காப்பாத்திட்டீங்க பேரை.
Thank you, sir.
Thank you, Dr. Kalpana. As Kalpana has already told, we realize that there is a high demand of skin grafts needed for not only just burn patients or blast injuries, acid burn patients, RTA, all those patients. So hopefully we can, we have a burn center in Sivagasi GH, but we don't have a skin bank. So hopefully we can establish one. Thank you, Dr. Kalpana. I invite my next speaker, Dr. Praveen Kumar sir, DO DNP FRCS. Finished MBBS. He has finished MBBS and post graduation in Ramachandra Medical College 2001 and DNP in ophthalmology from Rajan Eye Care, Chennai. He did his FRCS in 2007. He's worked in Rajan Eye Care, Chennai, St. Joseph, Trichy, and was in charge of Dr. Aggarwal's Eye Hospital, Kanchipuram. Currently, he is a phaco-refractive surgeon and medical retina specialist in Dr. Anil Kumar Eye Hospital. His various representations, he has various representations in his credit. Recently, his novel technique in capsulorhexis in mature cataract was published in All India Ophthalmology Society Journal. Apart from ophthalmology, he does soap carving, painting, and an avid photographer too. It's a pleasure to have you with us, sir.
Okay.
Welcome, Dr. Praveen.
Good evening. Good evening. Sorry for the delay. There are some. This is the first time I'm trying to share on this new system. So I would like to thank the Organ Donation Committee for giving this opportunity to speak about corneal transplantation. So I'm Dr. Praveen from Shivakasi. So actually, everyone spoke a little, too much in detail. This is a very simple talk, just to give an overview about corneal transplantation. So just to recap, our cornea has 5 layers: the epithelium, the Bowman's, the stroma, the decimates, and the endothelium. Actually, there's a new layer called as the Duas layer, which was invented by an Indian scientist, Indian doctor. This Duas layer is in between the stroma and the decimates membrane. So the physiological function of the cornea is it is the most important refractive surface of the eye, and it contributes to around 60 to 70% of the refractive power of the eye, and it protects our intraocular contents, and it maintains the shape of the eye and regulates the IOP. And it is through the cornea that majority of the topical medications are absorbed, and it is a highly sensitive organ with a lot of nerve endings. So what is corneal blindness? Corneal blindness is opacification or whitening of the transparent part of the cornea, causing functional impairment or blindness. So, coming to the history of corneal transplantation, though corneal transplantation keratoplasty was termed way back in 1818, the first successful corneal transplant was conducted in 1906 by Edward Zim. Following which corneal transplantation was developed by Dr. Filtow during the period of 1910 to 1950. And until 1974, until the McCary and Kaufman, they developed the corneal storage medium, which is called as the MK medium. The corneal transplantation was not a big this thing, because cornea used to decompose very fast, and only after the advent of MK medium, the corneal storage was developed. The cornea was able to be surveyed. We are able to save the corneal tissue for around a week or so, because even then we try to maximum transplant the cornea within 7 days. After that, the newer lamellar keratoplasty is developed. They came after the year 1998, around 2000, where the first was the DALCA, the deep anterior lamellar keratoplasty, and then in 2006, DSEC, that is the posterior lamellar keratoplasties, came into vogue. So, coming to the visual burden, around 285 million people in the world are globally visually impaired, out of which around 39 million are totally blind, of which India hosts 1/3 of the world's blind population. And new cases of around 40,000 patients are added every year. And out of the 13 million, around 2.5 to 3 million people are blind due to corneal pathology. That is, corneal blindness accounts for about 2.5 million in India. So the corneal blindness is the 5th leading cause of global blindness, and this corneal blindness has a very important treatment, that is the corneal transplant, and it is one of the most successful transplants, because it is one of the immunologically privileged organs or tissue in the body which has the highest successful transplantation results. So corneal transplantation, known as the corneal grafting, is a surgical procedure wherein the diseased cornea is replaced by the donor corneal graft. When we transplant the whole thickness, we call it as the penetrating keratoplasty. When we transplant a layer of the cornea, we call it the lamellar keratoplasty. So the indications for keratoplasty range from being optical, that is to improve vision, the tectonic is to restore integrity in case of injuries and trauma. Therapeutic, therapeutic keratoplasty is done where the cornea is transplanted to reduce the infective load or to remove the infection of the cornea. So optical keratoplasty, the indications are, the most commonest indication is the bullous keratopathy. We call it, due to endothelial loss. The commonest causes are, post-operative pseudophakic bullous keratopathy or aphakic bullous keratopathy, followed by other corneal dystrophies like the Fuchs endothelial dystrophy, which leads to corneal decompensation by itself. And the other optical reasons are the keratoconus and corneal traumatic scars. These are the main reasons where we transplant the cornea for the reasons of optical reasons, that is to improve the quality of vision. And this is an image of a corneal ulcer with severe hypopyon, which is not responding. And these kind of corneal ulcers which don't respond to medical management will require therapeutic kertoplasty to remove the diseased cornea and change for a donor tissue. Tectonic kertoplasty is in situations where we use a part of where we use not the whole cornea, where we use a segment or a wedge of a cornea to add strength to a diseased portion or to a traumatic or injured portion of the cornea. So cornea, the master tissue. No, like cornea can be considered as a master tissue because it's a very versatile tissue where it's just not one whole tissue. We can use multiple layers of the tissue for treatment. And as told earlier, not much of tissue matching is required for cornea, and there is nothing called as tissue matching in corneal transplant, and that is the reason it is one of the highly successful transplantations worldwide. There are studies suggesting that one corneal button can treat up to 4 people, but though it has not been proven and it is not into vogue, normally we call it one corneal button can be used to treat for at least 2 people, 2 eyes. So that is the beauty of this cornea. So this corneal transplant, as I told earlier, it can be divided into 2 categories: the penetrating and the lamellar kertoplasty. Penetrating is wherein we use the whole button, whereas in lamellar it is either anterior lamellar or posterior lamellar. Anterior lamellar is the one wherein we use the epithelium, Bowman's membrane, and the stroma, whereas in the posterior lamellar kertoplasties we use the posterior 3 layers, that is the Duas layer, the decimates, and the endothelium. So depending upon the level of incision, we can call it either the anterior lamellar kertoplasties or the posterior lamellar kertoplasties. So this is an image of a penetrating kertoplasty wherein the full thickness of the cornea is transplanted either for optical reasons or for therapeutic reasons. So in a therapeutic kertoplasty, the whole button of the cornea is removed in cases where there is a total thickness of issue of the corneal button, and the whole cornea is transplanted. This is the full thickness penetrating kertoplasty. So coming to this is just a surgical video showing wherein we remove the whole corneal button as such, and this is a total penetrating kertoplasty, where we call the open sky procedure, where the anterior chamber is totally exposed and the whole button is placed on the graft on the donor side, and normally 16 interrupted sutures are preferred to keep the graft in place. So this is the penetrating kertoplasty. This penetrating kertoplasty has been in vogue for a very long time, and even now we use penetrating kertoplasty as the second stage in case we are not able to complete the lamellar kertoplasty. And the only disadvantage with the penetrating kertoplasty is because there are multiple sutures involved, there are higher chances of astigmatism post-operatively, which can lead to a little poorer quality of vision. Whereas the other point is when the whole button is transplanted, there are higher chances of rejections compared to the lamellar kertoplasties. So that is the main reason, and because it is we are in lamellar kertoplasties, we are not opening the whole globe. The globe integrity is better and lesser chances of infection and lesser chances of graft rejections. So then came the lamellar kertoplasties, wherein we started using specific lamellae for the layer of cornea which is damaged. As I told earlier, the anterior epithelium, Bowman's, and the stroma, the front 3 layers comprise the anterior lamellar kertoplasties, and the posterior 3 layers wherein the duas, decimates, and endothelium comprise the posterior lamellar kertoplasty, as you can see in the schematic diagram, which layer is used for which type of kertoplasty. So as the same picture showing the sections of which level of the 3 different procedures. So anterior lamellar keratoplasty, this procedure is most commonly used for following corneal ulcers, wherein there is a corneal opacity in the anterior stroma, or in cases of keratoplasty, wherein there is stromal thinning and corneal protrusion. So here again we use the stroma for the support of the cornea, and these two are the most commonest indications for anterior lamellar keratoplasty. This anterior lamellar keratoplasty is again like divided into three types, wherein we use a manual method, and we use wherein there are two other things. One is the motorized anterior lamellar keratoplasty, where we use a microkeratome, or a femtolaser assisted sutureless anterior keratoplasty. So these are the two higher end these things. But most commonly anterior lamellar keratoplasty is the manual DALK is the most successful procedure. So so this is a surgery of a DALK procedure, wherein the anterior lamella, anterior portion of the cornea up to the stroma is transplanted, preserving the posterior Descemet's membrane. That is, we are not entering where we are not entering the eye, because the endothelium is the most important layer of the cornea, which maintains the transparency of the cornea by keeping it dehydrated without edema. So in this DALK surgery, an anterior lamellar, the groove is created, and 75% of the anterior lamella is removed, followed by what we call as a big bubble technique, where we inject air inside the stroma and we push the Descemet's behind, and then we make 4 leaflets of the anterior stroma, and we remove the anterior stroma up to the Descemet's membrane. So you can see this is not a full thickness, and the whole globe is intact, because the Descemet's membrane along with the endothelium is still holding the anterior chamber. So taking a button, we just remove the posterior endothelial layer, and here again we put the sutures, and we maintain the globe's integrity. And this is an intraoperative keratometer to see the astigmatism or tight or loose sutures by the end of the surgery. Because this is a closed globe, because we have not entered the globe and the Descemet's is still intact, this procedure doesn't require as many as 16 sutures. 8 to 10 sutures is enough, and this doesn't induce much astigmatism, and you get a very good visual potential after this procedure, because the rejection rates are very less. So Bowman's layer transplant is not a very successful thing. And the most commonest, apart from DALK is, as I told you, for optical reasons like corneal opacities and stromal dystrophies, and for keratoconus. The most commonest other procedure is the endothelial keratoplasty, wherein the diseased endothelium is replaced. That is, when the endothelium is diseased, as I told you, endothelium is the one which maintains the transparency of the cornea by the endothelial pump. It keeps the cornea dehydrated by not getting it hydrated. So when the endothelial cell count comes down, the endothelium, the cornea becomes edematous, and it will start developing bullae, and there will be defective vision. And this happens, in conditions like a post-operative pseudophakic bullous keratopathy, aphakic bullous keratopathy, and in other corneal dystrophies like the Fuchs endothelial dystrophy. These are the 3 most commonest causes of endothelial cell loss. So again, in the posterior lamella, there are 3 types. One is the DSEC, which is called as the Descemet stripping endothelial keratoplasty. Here, the Descemet stripping endothelial keratoplasty, apart from the endothelium, then the Descemets and the duas, there is about 50 microns of stroma. And to say about the beauty of this corneal transplant is, we are speaking in microns. The whole thickness of the cornea is 500 microns, which is actually 500 microns means 0.5 millimeter. That is half a millimeter. In a scale, we see 2 lines. That is 1 millimeter. The whole thickness of the cornea is 0.5 millimeters, 500 microns. So we are speaking something like, all these levels and layers, we are speaking these 5 layers within 500 microns, which is 0.5 millimeter. And so in DSEC, apart from this Descemet's layer and Duas layer, we use 50 microns of stroma. So the main advantage of DSEC is the tissue handling is little better, because the whole tissue, including the stroma, is around 80 to 90 microns. Whereas in Decimet's membrane endothelial keratoplasty, the DMEC, we use only the Decimet's and the endothelium. So the two tissues combined together is only 27 microns. So that, and PDEC includes the Duas layer. So the thickness of PDEC tissue is around 42 microns. So all these things are in microns. So because there is amount of stroma involved in the DSEC, the quality of vision is a little less compared to the PDEC and the DMEC. So in DSEC, we can expect a maximum of about 618 to 612 vision, whereas in DMEC and PDEC, we can expect around 69, that is around 90 to 95% of vision after a corneal transplant. That is the level of success rate with these procedures. So this is an animation of a DMEC procedure, wherein we first stain the endothelial side of the eye, and we remove the endothelium. We go in with a reverse Sinski kind of instrument, wherein we peel the whole endothelium and we remove it. Once we remove the endothelium, we prepare the donor endothelial scroll, and we take it in an injector, and we inject it into the anterior chamber, and we unroll the graft, and we put air bubble inside the anterior chamber to lift the graft to stick to the endothelial side of the cornea. So this is the endothelial keratoplasty. Again, just a surgical video of this thing. As I told earlier, we make a mark of about 8 millimeter diameter for the corneal endothelial guidance, and we, using a reverse Sinski, we strip the whole endothelium, and we remove the endothelial side. After that, as I told earlier, we make the graft out of the donor tissue. We remove the central part, the discoid portion of the endothelium. See, as you can see, it will be like a small plastic paper. We inject the endothelium into the anterior chamber, and we normally suture the hole. We suture the incision, or else the graft may come out. And by anterior chamber maneuver, we unroll the graft, and we put air bubble so that it sticks to the posterior portion of the cornea. Normally, this air bubble stays for about 24 to 48 hours. By this time, the corneal endothelial scroll gets attached to the host tissue. So again, apart from these three beautiful procedures, there's a new upcoming procedure where this corneal stroma is used. As I told earlier, I was telling that in the end stages of keratoplasty, in keratoconus, we use the whole corneal button for a tectonic support for the thinned out cornea for keratoconus. A new procedure called CARES, which is the corneal allogenic intrastromal ring segment. Here, as I told, this cornea starts bulging because this stroma becomes thin. So as a support for this thinned out cornea, with the new procedures, like there are two ways of making a tunnel. We call it the intrastromal ring segment. We make arcuate tunnels in the cornea, either using a femtosecond, or there are manual trifines to make the segments. So we strip the cornea depending upon the weak areas. We use these segments, and these are transplanted inside the host cornea. All this, like within the 0.5 millimeter of the cornea. So this gives support to the place where the cornea is protruding and bulging, which is causing defective vision. These segments add strength, tectonic support to the cornea, which is becoming thinner. So these are the places where corneal transplantation helps. And newer modalities of synthetic corneas and keratoprosthesis, where we use acrylic plates instead of corneas. And there's another thing called as OOKP, where we use the patient's tooth. We implant the tooth in the cheek, and once the tissue grows over the tooth, they drill it, and they put an acrylic tube inside the tooth. And like these are situations where corneal transplantation is not viable due to conditions like severe dry eye or exposure, wherein the corneal graft may fail. So synthetic corneas and stem cells are all in research, but still this corneal transplantation as such has a high successful rate. The only thing is meeting the demand. So corneal transplantation is relatively happening everywhere, but still more number of donors will help reduce the present burden present everywhere. And as I told earlier, this is a very highly successful transplantation which will add benefit to the society. And the contraindications of cardioplasty are just like in any other thing, like death due to unknown cause, CNS infection, septicemia, and cancers like lymphomas, leukemias, intraocular tumors, and like death more than 6 to 8 hours, seropositive patients. These are the regular contraindications which we also follow for the corneal transplantation. And as I told earlier, full thickness cardioplasty has a graft survival rate of about 70%, whereas the newer procedures like DSEC and DMEC have a success rate of about 98% as per literature. But even in practice, we have seen very high success rate, not just the graft, and a very good visual potential. Earlier and all, we used to say ambulatory vision. Nowadays, we are able to get more than 75 to 80% of optical visual quality in corneal transplants. Thank you.
Dr. Praveen, sir. As sir
Yes.
said, this surgery requires a lot of expertise and requirement of a very good donor
Infrastructure.
quality tissue.
And
So and the demand is too high. And every, as Dr. Rajesh Babu sir is saying, every IMA should have an retrieval center, and hopefully eye banks also will come up in good amounts. Thank you, sir. Thank you for the good talk and good videos. Dr. Rajesh, sir.
Oh, good afternoon.
Good afternoon,
So
sir.
today the meeting was of high quality. In the organ donation meeting, we have seen a lot of things, and even in the eye donation also. Regarding this anesthesia, Dr. Pawan Pandian has given an exhaustive remarks about the anesthesia. And regarding the blood transfusion, the apheresis was exhaustively discussed by Dr. Anandiswari. And corneal transplantation, Dr. Praveen has given a wide view. And regarding the kidney transplantation, Dr. Ashok has given a wide idea. And the skin bank, regarding that, Dr. Kalpana has given a wide view about that. And Madam, you can ask some questions from the chat box. You can go through the chat box and you can start asking questions from that. There are some questions which are seen there, which always our Dr. Sundaramurthy used to put it there. So we will put one question here and there. Dr. Kalpana is what specialty, madam? Dr. Kalpana?
Dermatology, sir. Dermatology.
Yes, sir.
Dr. Kalpana is there?
Yeah, sir. I'm here.
Madam, whether you are doing skin retrievals, you doing there or not yet started
No,
yet?
sir. No, sir. We don't have a skin bank here in Sivagasi.
So we have a burn center there,
Burn center?
Sivagasi GH.
Yeah.
But
No, madam, you are giving an exhaustive lecture about that now.
sir, we are
Always
sir, we are on the tube.
Madam, you people have to. You have plastic surgeons there in your
Yes, sir.
department.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So
Number
hopefully
one
in
is
1 or 2 months we will 1 or 2 months we actually I had prepared a letter to submit before the health secretary or health minister to have a visit to the government Stanley Hospital. But then if Ganga Hospital is having a skin banking, can we have a visit there, sir?
Madam, you send a letter to Ganga Hospital.
Okay,
You
sir.
can come and see, madam. You
Okay,
can put
sir.
a letter.
Yeah.
I will send the email IDs.
Okay, sir.
You can send a letter to our hospital, and
Okay,
then
sir.
you can get an appointment, and then you can do it, madam. To visit the
Sure,
skin
sir.
bank.
Sure.
You want to see, you can tell.
Okay, sir.
And then you can get it done, madam. That is the thing. Yeah?
Okay, sir.
That is the thing. So regarding the skin bank, you can create from your place, and you can let it be a first center from a peripheral area instead
Yes,
of
sir.
from the centers. It can be, and the same way it can be connected to the IMA also, so
So
that
we are
Sevaga
planning with
CIMA,
IMA only.
Sevaga CIMA can be the role model for the whole country. I
We are
wish,
planning
I
with
wish,
IMA only,
I
sir.
wish it has to happen, madam.
Okay,
I
sir.
wish you all the success, madam.
Thank
That
you,
is the
sir.
thing. You can ask some questions from the chat box, madam. Regarding this corneal transplantation, Dr. Praveen has given exhaustive discussion about the corneal transplant and the tissue transplant and everything. Was very, very nice. Any questions from the audience needed? நீங்க என்ன கொஸ்டின்ஸ் கேளுங்க மேடம். இதுல இருக்க chat boxல இருக்க chat box பார்த்துட்டு இருக்கீங்களா?
Sir, chat boxல பெருசா இல்ல sir. Somebody want to remember skin donation done by respected Dr. Ratnevel Pandian sir in Stanley Medical College. Other than that, questions, any impact of COVID-19 patients on eye donation now? I don't think so, sir. COVID-19 doesn't have any impact on any eye donation. Because cornea is avascular tissue. So it is very safe in transplantation. Unless HIV,
Madam,
HBsAg.
actually, for saying it is not needed. But even when you are putting contraindications, it used to come like that now.
Okay, sir. There's
That's what
HIV,
usually they used to
HBsAg is
put
there.
HIV, HBsAg, everything. See, actually, everything they can take it because when they are coming for the eye donation, when they are taking the eyes, they are giving the form and they are taking the blood now. So at the time, if it is a positive, they may not use it. That is the problem, madam.
Yeah.
So that is the contraindication still exists and can't be used. That is the thing. And one question from Dr. Sundaramurthy is absolute contraindications for organ donation. Absolute contraindication for organ donation. Nephrologist sir, Dr. Ashok is there?
Yes, sir, I'm available. Yeah, I'm there, sir.
Absolute contraindication for organ donation.
Active infection, active malignancies. These are all the absolute contraindications. Nowadays, blood group and other HLA, these things we can overcome, sir. Absolute contraindications are nowadays like active, when the recipient is having active infection and active malignancies. These are the absolute contraindication.
Is polycythemia blood fit for donation? That is another question.
Sorry, sir, didn't get.
இவங்க blood donation, madam, பேசணும். Transfusion medicine, madam. Is polycythemia blood fit for blood donation? Anandiswari madam is there? Madam இல்லைன்னு நினைக்கிறேன். Sir, do you want to answer that? Nephrology, sir?
Good question, Virgo.
Is polycythemia blood fit for donation?
Anandishwari ma'am? Anandishwari ma'am?
Sir, another question is epidural anesthesia safe for organ donation? Anesthetist sir இருக்காரா?
Sir, anesthetist sirக்கு ஒரு emergency case இருக்கனால he has
சரி
left
madam,
the
okay.
Hello, ma'am, உங்களுக்கு ஒரு question இருக்கு.
Most common cause of organ rejection in organ donation patients. Nephrologist sir? Nephrologist sir?
Sir, Ashok sir?
Yeah, I'm there, sir. Can you repeat the question, sir?
Most common causes for organ rejection in organ donation patients.
think skipping the immunosuppression and chronic antibody mediated rejection is a main cause. Like inadequate immunosuppression, like skipping the medication is the most common cause.
Then another question is,
Dr. Kalpana, there is a question regarding concept of artificial skin in future. Is Botox injection alternative to skin grafting?
no, automatic skins are available, madam, but the cost is more.
Yeah, it's costly, ma'am.
Cost is very
That's
high,
why
madam.
high.
ஒரு 10 into 10 centimeter வந்து 50,000 rupees. 10 centimeter into 10 centimeter வந்து 50,000 rupees. அதே வந்து ஸ்கின் பேக் ஸ்கின் வந்து காஸ்ட் வந்து வெரி லெஸ்.
Cadaveric skin is the cheapest alternate, ma'am.
And there is another question: is Botox injection alternative to skin grafting?
No, skin grafting is entirely
That cannot
different
be.
from
That cannot be,
Botox.
madam.
That cannot be put for. It's entirely different, ma'am.
Yeah. Anandishri, ma'am, are you there?
There is one question: opinion on pancreas donation for type 1 diabetes. Anyone want to answer? There is one question from Dr.
Ashok,
Sundaramurthy, sir. Any
Ashok.
unique barrier in renal transplant in India and abroad countries?
Sir, I will answer that question, sir. In India, when compared to the Western countries, the various studies have shown that the knowledge and perception regarding the transplant knowledge for the recipient seems to be limited, particularly in the lower socioeconomic status when compared to the Western countries. And that's the reason many patients in the lower economic status, they don't go for transplant. They have various fear and misconceptions regarding the transplant and the post-transplant care, all these things. So that is a unique barrier which we face in India.
Another question is age and gender issues in renal transplant.
Yeah, in there is a gender bias is there in the renal transplant. When we see the percentage of donations among the women tend to donate more than they receive. So this gender issue is there, and age like the according to the guidelines, the cutoff age is up to 60 years, they say, for a good graft. So sometimes for the organ shortage, we used to expand the donor criteria. So these are the issues which we are facing in the renal transplant, age and gender issues.
The gender issue is also there.
Yeah, gender issue I addressed. I told that women tend to donate more than they receive.
Madam,
Okay.
women are donating more than men. That is the rule. That's what happening, madam.
Okay.
நாங்க டாக்லயே அது சொல்லுவேன் ஆக்சுவலா. women are tend to donate more than men அப்படிங்கிறது பாயிண்ட். 80:20%. அப்புறம் வந்து ஏன்னா நான் வந்து ஆர்கன் டொனேஷன் ரிலேட்டடாக வந்து ஐ எம் கிவிங் டாக்ஸ் ஃப்ரம் 2010 ஆன்வர்ட்ஸ்லேருந்து ஐ எம் லுக்கிங் ஆஃப்டர் தேட். ஸோ அதனால் வந்து என்னென்ன லேட்டஸ்ட் ட்ரெண்ட்ஸ் வருதோ எல்லாமே நம்ம பண்ணுவோம். ஈவன் இப்போ பார்த்தீங்கன்னா இப்போ லேட்டஸ்ட் வந்து பிரெயின் டெத் சர்டிஃபிகேஷன் வந்து ரூல்ஸ் எல்லாம் மாற்றிட்டாங்க ஆக்சுவலாக ஆஸ் பர் த டிரான்ஸ்பிளான்ட். இப்போ வந்து இந்த ஆப்னிக் டெஸ்ட் இதெல்லாமே கூட பண்ண வேண்டியதில்லை. இந்த 4 வெசல் டெஸ்ட் வந்து அப்நார்மல் இருந்தால் தான் தென் ஒன்லி இட் வில் பி டேக்கன் எஸ் பாசிட்டிவ்னு சொல்லி வச்சிருக்கிறாங்க. பட் அது கூட பண்ணுறது ரொம்ப டிஃபிகல்ட் ஆக்சுவலாக. அது வந்து ஆஞ்சியோகிராம் பண்ணணும். ஆஞ்சியோகிராம் வந்து பெட் சைட் பண்ணுறது வெரி டிஃபிகல்ட். அது வந்து கேண்ட்ரியில் கொண்டு போய் தான் பண்ணணும். ஸோ தட் இஸ் த திங். அண்ட் ஹவு மெனி சென்டர்ஸ் ஆர் ஃபாலோயிங் இட் அப் இட் இஸ் நாட் நோன். தட் இஸ் த திங். அப்புறம் வந்து இன்னொரு கொஸ்டின், டஸ் ஸ்டெம் செல் தெரப்பி ஓவர் கம் ஆர்கன் அண்ட் பிளட் டொனேஷன்? அவங்க மேலே போயிட்டாங்க போல இருக்கு. அப்புறம் டாக்டர் கேட்டிருக்கிறார், ரிக்வெஸ்ட் ஐஎம்ஏ டிஎன்எஸ்பி டு ஸ்ட்ரெஸ் ஃபார் மோர் ஆர்கன் அண்ட் பிளட் டொனேஷன் த்ரூ ப்ரெஸ் அண்ட் டிவி சீரியல்ஸ் அண்ட் ஃபார் ஜாப் ப்ரியாரிட்டி ஃபார் டோனார் அப்படின்னு கொடுத்துருக்காரு. ஸோ அதெல்லாம் பண்ணலாம். அதெல்லாம் வந்து வி ஹேவ் டு டேக் இட் டு தி கவர்மெண்ட் அண்ட் தென் வி ஹேவ் டு டிஸ்கஸ் வித் த கவர்மெண்ட் பீப்புள். அண்ட் ஈவன் வந்து ப்ரெஸ் அண்ட் டிவி சீரியல்ஸில் கொடுக்கலாம். பட் அதை விட நம்ம வாட்ஸ்அப்பில் வந்து நியூவாக வந்து ஃப்ளையர்ஸு, இது ஸ்மால் வீடியோ கிளிப்பிங்ஸு இது மாதிரி எல்லாம் கொடுத்து வி கேன் ப்ரொடியூஸ். இப்போ ஈவன் ஃபார் எக்ஸாம்பிள் ஈச் மீட்டிங் நான் வந்து ஐ யூஸ் டு புட் ஒன் வீடியோ ஆல்வேஸ். ஏதாவது ஒரு வீடியோ எங்கே இருந்தால் அது இப்போ இந்த வீடியோ இன்னைக்கு போட்ட மாதிரி தான் அந்த ஆர்கன் டிரான்ஸ்பிளான்ட்ஸ் போட்டிருந்தாங்க இல்லைங்களா, அதே மாதிரி வீடியோ ஐ யூஸ் டு புட். There are a lot of videos I used to put like that. That is the thing. Any possibilities for artificial blood in future? Certainly give steroids and antihistamines before blood transfusion கேட்டிருக்கிறாரு. அது பூரா கொஸ்டின்ஸுமே நம்ம இவர் தான் சுந்தரமூர்த்தி சார் தான். அப்புறம் வந்து இஸ் ஐ டொனேஷன் மோர் இன் அர்பன் ஆர் ரூரல் ஏரியாஸ், நீட் டு ஃபோக்கஸ் மோர் இன் ரூரல் ஏரியாஸ் ஆல்சோ அப்படின்னு போட்டிருக்கிறாரு. அந்த ரூரல் ஏரியாஸ் எல்லாம் டெவலப் பண்ணுங்கிறதா என்னுடைய கான்செப்ட். அதுக்கு தான் வந்து நான் வந்து எல்லா இடத்துலையும் ஐபேக் ஸ்டார்ட் பண்ணுங்கன்னு சொல்லிட்டு இருக்கிறேன். எனக்கு வந்து அதெல்லாம் வந்து கோஆர்டினேட் பண்ணி பண்ணுறதுக்கு டைம் இல்லை. அதனால தான் ஐ வாஸ் நாட் ஏபிள் டு டூ இட். அது ஒரு நம்ம ஒரு ரேலி மாதிரி நம்ம வந்து த்ரூ அவுட் தி ஸ்டேட் வந்து நம்ம போகணும். நீங்கள் வந்து ஃபஸ்ட்டு வந்து ஒரு ரிட்ரீவல் சென்டர் வந்து சிவகாசியில் நீங்கள் ஸ்டார்ட் பண்ணிட்டீங்கன்னா அதே மாதிரி கோயம்புத்தூர்லேயும் ஒன்று ஸ்டார்ட் பண்ணுறதுக்கு வாய்ப்பு இருக்குது. ஸோ அந்த மாதிரி வச்சுட்டு அதிலிருந்து டைரக்ட்லி வி வில் கோ டு ஆல் த எந்தெந்த ஏரியாக்கெல்லாம் அங்கங்கே இருந்து ஆட்கள் போக முடியுமோ அதே மாதிரி நம்ம ஒர்க் ஷாப்ஸ் கண்டக்ட் பண்ணி நம்ம வந்து கொஞ்சம் எஜுகேட் பண்ணால் ஹூ ஆர் ஆல் வில்லிங் அப்படின்னு சொல்லிட்டு நம்ம வந்து கிரியேட் பண்ணி நல்ல விதமாக கொண்டு போகலாங்க சார். ஸோ அதுக்கெல்லாம் வந்து நீங்கள் எல்லாம் ஒத்துழைச்சா பண்ணிக்கலாங்க சார். இப்போ பிரவீன்குமார் சார் வந்து ரொம்ப ஆக்டிவாக இருக்கிறீங்க. ஸோ இந்த மாதிரி வந்து நான் என்ன சொல்கிறேன்னா இது வந்து ஒன்றுமே கஷ்டமே இல்லைங்க சார். ஐ ரிட்ரீவல் சென்டர் எல்லா இடத்துலையும் வைக்கிறது வேறு கஷ்டமே கிடையாது. அது வந்து ரிட்ரீவல் பண்ணுறது வந்து இட்ஸ் நாட் அட் ஆல் டிஃபிகல்ட்டி. அதுக்கு வந்து பண்ணுறதுக்கு ப்ரொசீஜரை வந்து ரொம்ப சிம்பிளிஃபை பண்ணுறதுக்கு கவர்மெண்ட் கிட்ட ரிக்வெஸ்ட் பண்ணி வி ஹேவ் டு டூ இட். அதுக்கே வந்து நம்ம வந்து ஆக்சுவலாக பார்த்தீங்கன்னா இப்போ வந்து நம்ம அப்ளை பண்ணி அதை வந்து அவங்க டிஎம்எஸ் ஆஃபீஸுக்கு வந்து இன்ஸ்பெக்ஷன் பண்ணி அதுக்கப்புறம் தான் அவங்க அப்ரூவல் கொடுக்குறாங்க. அதெல்லாம் வந்து இட் டேக்ஸ் அ லாங் ப்ராசஸ். அந்த அளவுக்கு அது பண்ண வேணுமா அப்படிங்கிறது தான் என்னுடைய இது. ரிட்ரீவல் சென்டர் பண்ணுறதுக்கு அங்கங்கே லோக்கல்லேருந்து அங்கேருந்து மெடிக்கல் காலேஜஸ்லேருந்து தே கேன் சர்டிஃபை அண்ட் கிவ் இட். தட் இஸ் நத்திங் ராங் இன் டூயிங் இட். இப்போ பார்த்தீங்கன்னா இப்போ உடுமலைப்பேட்டிலேருந்து இவர் அங்கே ஒரு ஜென்ரல் ஃபிசிஷியன் அவர் வந்து ஒன்லி எம்பிபிஎஸ் டாக்டர் தான். அவர் வந்து லயன்ஸ் கிளப் மூலமாக வந்து இஸ் ரிட்ரைவிங் ஐ அண்ட் இஸ் டூயிங் லாட் ஆஃப் திங்ஸ். அதே மாதிரி ஐ எடுக்கிறதுக்கு வந்து பார்த்தீங்கன்னா இங்கே மேட்டுப்பாளையமில் வந்து கோயம்புத்தூர் பக்கத்தில் மேட்டுப்பாளையத்தில் வந்து பார்த்தீங்கன்னா கவர்மெண்ட் ஹாஸ்பிட்டலில் பேஷண்ட் செத்து போயிடுச்சுன்னா ஜிஹெச்லேயே வந்து ஒரு ஸ்டாஃப் நர்ஸ் தான் வந்து ஐ எடுப்பாங்க. அந்த ஸ்டாஃப் நர்ஸ் ரெகுலர்லி ஷீ கம்ஸ் அண்ட் டேக்ஸ் தி ஐ. அதனால நம்ம வந்து சும்மா வாலண்டியர்ஸை நம்ம ட்ரெயின் பண்ணால் போதும். இதுக்கு வந்து பெரிய அஃபிஷியலாக பெரிய பர்மிஷனு இதெல்லாம் ஒன்றும் வாங்க வேண்டியதில்லை. தட் இஸ் தி ஸ்டேட்டஸ் நவ். ஸோ அதனால் ஐ ரிட்ரீவல் சென்டர் ஆரம்பிக்கிறது வந்து ஒரு பெரிய கஷ்டமே கிடையாது. தே கேன் டூ இட் ஃப்ரம் ஆல் த பிளேசஸ். ஒரு ஆப்தால்மாலஜிஸ்ட் ஒரு ஏரியாவில் ஒருத்தர் எடுத்துட்டா போதும். ஒரு ஐஎம்ஏலேருந்து ஒரு 2 ஆப்தால்மாலஜிஸ்ட். அதுக்கு வந்து நீங்கள் யாரெல்லாம் ஆப்தால்மாலஜிஸ்ட் பார்க்குறீங்களோ அந்த ஆப்தால்மாலஜிஸ்ட்டுக்கெல்லாம் நீங்கள் பேசி நீங்கள் எந்த ஐஎம்ஏ நீங்கள் வந்து ரிட்ரீவல் சென்டர் ஆரம்பிங்க, நீங்கள் பேசுனீங்கனாலே போதும். இன் தட் மேனர் ஒன்லி வி கேன் மேக் இட். ஸோ அந்த முறையில் நீங்கள் பண்ணீங்கன்னா மினிமம் ஒரு 50 பிரான்ச்சில் எடுத்தாலே 50 பிரான்ச்சிலேருந்து ஒரு ஐ வந்தாலே போதும் ஒரு மாதத்துக்கு. உங்களுக்கு வந்து அதில் வந்து ஆட்டோமேட்டிக்காக 50 ஐ வந்துடும் சார். அதே வந்து ஒரு 12 மாதத்துக்கு போட்டிங்கன்னா அதே ஆச்சு 600 ஐ ஆச்சு, 600 பேரவை ஆச்சு, 1200 கன்று வந்துடும். ஸோ அதனால வெரி சிம்பிள் கால்குலேஷன் சார். நான் வந்து எப்பவுமே வந்து திங்க் பண்ணுறதே வந்து டிஃப்ரெண்ட்டாக தான் திங்க் பண்ணுவேன். ஜஸ்ட் லைக் தட் அப்படியே எல்லா இடத்துலையுமே பண்ணணுங்கிறத என்னுடைய கோட்பாடோடயே இருப்பேன் ஆல்வேஸ்.
கண்டிப்பா சார், பண்ணிடுவோம் சார்.
ஸோ அதனால நீங்க வந்து செட்டிங் அஸ் அன் எக்ஸாம்பிள் ஃப்ரம் த பெரிஃபேரியிலிருந்து இஃப் யூ ஸ்டார்ட் டூயிங் இட் இட் வில் ரீச் லைக் அ ஃபயர். அதுதான் என்னுடைய இது.
ஷூர் சார், பண்ணிடுவோம். ஷூர் சார்.
பட்டாசு கொடுக்கக்கூடிய சிவகாசியிலிருந்து இந்த மாதிரி பெரிய பெரிய பட்டாசு வெடிக்கணும் நீங்க. மேடம் வேற ஏதாவது இருக்கீங்களா? வேற ஏதாவது இருந்தா சரி, அதர்வைஸ் we will close the program.
Okay, Anandeshri ma'am, she says she's connecting.
பரவாயில்ல, விட்டுருங்க, அவங்களை டிஸ்டர்ப் பண்ண வேண்டாம். பரவாயில்ல, ஒன்றும் பிரச்சனையே கிடையாது.
Okay,
most of the questions are answered.
Okay
so
sir.
at the outset from the organ donation committee and blood and organ donation committee, I immensely thank Dr. Rashmi madam who has taken a lot of pain and she has done a great program. compared to all the other programs, this program is totally a different, and because the topics were given in a different manner, not like a blood donation, organ donation, body donation, podame. You gave in a different topics and different.
Student.
Totally, it was a totally different. Sir, Sukumar sir, நீங்க ஏதாவது சொல்லுங்க சார்.
சார் இல்லம்மா நல்லா பண்ணாரு. அது கார்னியா ரொம்ப டாப்பா பேசினாரு. என்ன அது இந்த கண்டாக்டருக்கே அவ்வளவு தெரியாது. அது இந்த அளவுக்கு எல்லாரும்
எக்ஸாஸ்டிவா பேசிட்டார் சார்.
எக்ஸ்டென்சிவா பேசிட்டார் சார். டூ மச். அப்புறம் அவங்க நல்லா ஸ்கின் டொனேஷன் பத்தி ரொம்ப பேசிக்கா நல்லா சொன்னாங்க. உண்மையாவே அது நிறைய பேருக்கு என்னன்னே புரியாம இருந்துச்சு. ஆனால் அதுவும் நல்லா செஞ்சுட்டாங்க. ரொம்ப சந்தோஷம். கார்னியா இட்ஸ் எக்ஸலன்ட் சார்.
தேங்க்யூ சார். தேங்க்யூ சார்.
தேங்க்யூ சார். அவர் ராஷ்மி மேடம் நல்லா பண்றாங்க. அவங்க இதையும் செஞ்சு முடிச்சுட்டு நீ அடுத்து ஸ்டேட் கவுன்சில் பண்ண போறாங்க. சிவகாசி
துர்வாசர் வாயில் ரிஷி அப்படின்னு சொல்ற மாதிரி இருக்கீங்க சார். பிரவீன்குமார் சார் உங்களுக்கு சுகுமார் சார் வந்து உங்களை பாராட்டுறது.
தேங்க்யூ 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 சார்.
ஹஸ்பண்ட் ஹஸ்பண்ட்
அது தெரியாது
சார். மிரட்டினதுலயே தெரிஞ்சுதே.
இல்லைங்க, நானே யோசிச்சேன், யாருக்கும் புரியல.
So it was a very nice discussion from Sivagasi, and like that you set as an example, and like that all the branches can do lot of meetings and lot of things and lot of new innovations, so that we can do wonders. Thank you one and all for joining the program. Thank you,
Thank
madam.
you, sir. Thank you, sir.
Thank you, sir.